Thank you so much, everyone, for joining. This promises to be a very interesting section. I have very wonderful guests and panelists on the call. So far, we have about quite a good number of people on the call. I think I'm looking at about 38 at this point in time. Thank you, everyone, for sparing some of your time to join us. It promises to be a very interesting and very rewarding and knowledge-filled section. We've been able to assemble some of the most interesting panelists or some of the most interesting professionals in public health across the continent. And by the time we are done, you should be able to understand a whole lot the centrality of data in public health practice and how it can help us to keep things safe for populations who depend on our professionalism to keep themselves safe from infectious diseases. For those who are not in the public health space, because I know there's quite a number of them, you will be able to learn and understand exactly the basis for some of the instructions or requests that we put out when there's an outbreak like the COVID-19. So sit back, relax, and enjoy. We're going to be making use of the question and answer button a lot. Even though there's a question and answer section when the panelists are done exhausting the knowledge that they've been able to prepare for this, you will be able to ask your questions, get to understand things better, and then allow us to also set things in better perspective. So without much ado, I would like to introduce myself. My name is Chinedu Anarado. I work for eHealth Africa as a project manager, overseeing a number of our disease surveillance initiatives on the continent and beyond. The purpose of this webinar is actually to deepen public health practice in Nigeria, but also to help us understand exactly some of the decisions that back what we do in this space. With me on the call will be other panelists, which I'll be introducing a little bit after the housekeeping. A couple of instructions. All panelists, please, we would like you to keep your videos open, at least until after we've done the introductions, and then we can shut it out and then focus on the section. All attendees, you would have an opportunity to ask questions. You could use the chat box. You could also ask during the question and answer section. During that period, I'll be able to identify those who would ask questions. Just raise up your hands and the EHA help desk will give you access to speak when the time comes. Regardless, there will be an opportunity for a lot of people to air their views or share some of their comments and thoughts, ask questions, and get to learn more from our panelists. This section is going to run for another 70 to 90 minutes. And across the section, we will be discussing data and disease surveillance, the concept of timeliness in emergency preparedness and how it helps us to prevent health emergencies, how to strengthen the capacity or the capacity gaps that we have and address some of the challenges across the continent and in Nigeria. The structure of this conversation is such that we are focusing on Africa or sub-Saharan Africa, but we are going to be using Nigeria as a case study, as a footstool, and also Kano State, which presents quite, you could understand the rationale. Nigeria is the most populous country in Africa, and Kano State returns some of the highest health emergencies burden in the country, and also putting some of the most work with regards to containing public health disease outbreaks, as the case may be. So you would have a lot of fun-filled time and a knowledge-filled section. That said, I will introduce my panelists, and we'll go one after the other. First on the panel is Dr. Emmanuel Agogo, who is the country director of Resolve to Save Lives. Dr. Emmanuel Agogo is a public health physician. He has a Bachelor of Degree in Medicine and Surgery from the University of Ibadan, and also an MSc in Tropical Medicine and Infectious Diseases, and another MSc in Clinical and Primary Health. He's been a family health physician with the National Health Service in the United Kingdom, but also been a strong technical expert with Africa risk capacity development. At some point in his career, he was the deputy director and the senior technical advisor at the NCDC, which is the Nigeria Center for Disease Control, and also an acting project director for the World Bank funded REDICE project. Dr. Agogo was also assistant director at the National Agency for Control of HIV/AIDS and has been a multiple consultant to the World Bank and the WHO. He's a fellow of the Johns Hopkins Center for Health Security, focusing on emerging biosecurity issues. He's also a fellow of the Kofi Annan Leadership Institute. Dr. Gogo, you're welcome on the call. Please, you could introduce yourself a little bit more than I have done, and then I can move into the next.
Thanks, Chinedu. I think it's a pleasure to be here. I think it's a work that we've been doing for a while. We've been working with Resolve to Save Lives at the subnational level, helping strengthen data for action use, working at with the NCDC really, to look at systems for improving preparedness at the national and subnational level, as well as some work around cardiovascular disease programs in Ogun and Kano states. Looking forward to the conversation today, and thanks for having me on the panel with other illustrious public health physicians in the lineup. Thank you.
Thank you so much, and we look forward to your wealth of knowledge and experience. Next on our lineup is Dr. Godwin Aban, who currently leads Information Systems, Innovation and Data Analytics at the World Health Organization Africa Regional Office. Dr. Aban is a very interesting person, one of the digital health intellectuals on the continent. He's been the brain behind a couple of mobile health interventions, GIS and accountability frameworks for digital health on the continent. He holds a Bachelor of Engineering degree in Electrical Engineering from Federal University of Technology, Owerri, and an MSc in Information Technology and another MSc in Public Health. He has a PhD in ICT for Digital and Public Health Intervention, and has been coordinated a number of electronic surveillance activities on the continent, particularly e-surveillance, or e-surv as they say in Afro, the ISS platform, and most illustriously, the autovisual AFP detection and reporting initiative, AVADA, which has been implemented, I think at the last count, across about 15 countries on the continent. At some point in his career, he was the zonal director and data and ICT manager at the United Nations, basically configuring several technology initiatives to support data collection, monitoring, and evaluation for most UN projects. He has authored or co-authored over 13 peer-reviewed publications, and is a certified data and ICT professional on the continent. One of the things or interesting things about, or one of the most proud moments I've had with Dr. Aban was actually watching him at the GIS Center for Health launch, basically providing the necessary case study on how to set up a global GIS Center for Health. Dr. Aban, welcome on the call, and a brief introduction for yourself.
All right, thanks, Chinedu. I don't know what to add to that. I think you've done all the deep dive into my career. But I'm very excited to be here today, and hopefully we will get to share some ideas how to move Nigeria and Africa forward, and also just generally give people that belief that they can do it too, and they can contribute to the public health space. I'm excited to see Dr. Agogo. We've worked a couple of times, and the public health space gets smaller and smaller. And Chinedu, you too. We've been collaborating on many projects, and this is the beauty about public health. We keep expanding, we keep meeting here and there, keep sharing ideas. So let's hopefully today, colleagues who have joined will gain a few insights here and there. We will be very open about this. Thank you.
Thank you so much for your time and for accepting to also be on the call. I'm sure we would benefit a lot from some of the interventions that you've led on the continent. Up next for us is Suleiman Hamisu Ilyasu. He's actually the person who would basically get to inform critical actors when there's an outbreak in Kano State. Suleiman is the Disease Surveillance and Notification Officer within the Kano State Ministry of Health, and also a focal character in the Public Health EOC in Kano State. He's a public health epidemiologist and DSNO for Kano State. And he holds a bachelor's degree in public health and an MSc in epidemiology and disease control. Suleiman is a fellow of the African Institute of Public Health and basically coordinates surveillance across all 44 local government areas in Kano State through some of the LGA surveillance officers. Suleiman has worked closely with eHealth Africa across some of the digital initiatives and data analysis projects that we've rolled out in that state. So he comes with a health of local intelligence and knowledge exactly on how disease surveillance works, and some of his perspectives on how we can improve systems will be very, very instrumental in terms of how we share knowledge across the continent. Suleiman, please introduce yourself and then say hi and welcome to our attendees.
Thank you. Okay, hello.
Yes, we can hear you. Go ahead.
Okay, good afternoon, everyone. Thank you very much, Chinedu. You're almost welcome for giving us this opportunity. So actually, I cannot even add everything of all what you have already said. You know, as you already know, Kano is a state that has a high number of people for the whole country. It's a high volume, and then it's a high volume people populous country, populous in the country. We actually really be very happily to be part of this this meeting, and I'm sure we are going to contribute to show the world how states it has been impacting, how we benefit from the health services and delivery across the Kano State, how we mitigate and respond to outbreak in Kano State. So we are always and almost welcome for this program. Thank you very much, and over. Thank you.
Thank you, Suleiman, and totally appreciate you setting out some time to join the call. Up next, we will then have an opening remarks from the Executive Director. David Aban is going to lead that effort, basically welcoming everyone to the call and setting the stage for the conversation. And after that, we can get right into it. David, take it away.
Thank you, Chinedu. So it's an honor to kind of open this very first webinar being led by eHealth Africa. And we're so delighted to have our distinguished guests and of course our attendees for this particular conversation. Just to say welcome to everyone. So it's going to be a very fruitful couple of minutes, and we're going to discuss and have great insight into how we could improve our public health response. So welcome everyone. Nice having you here. Thank you.
Thank you so much. Let's get right into it. So I'm going to try to set the stage with regards to the challenges that we've had around disease surveillance, especially as it relates to data use. And my focus is going to be on sub-Saharan Africa, and then we'll narrow it down to Nigeria and perhaps Kano State with some sort of attributes or characteristics applying to most other aspects of the continent and countries and states in Nigeria. And it is to say basically that scientific development with regards to strengthening health system to promote human and human health continues to be confronted by, long-standing, or Africa continues to be confronted by long-standing emerging or re-emerging infectious disease threats. We are vulnerable to infectious disease epidemics, largely because of our climatic and ecological conditions, which harbor disease pathogens and vectors in our environment. You're also looking at issues such as the high level of interaction between humans and animals. We're looking at migration of birds and animals which move across borders in an uncontrolled manner, especially as we trade and interact with other people from across the continent. And this sort of interactions pose very high threats to this, or basically present themselves as very important vehicles for the spread of infectious diseases. Unfortunately, Africa and indeed sub-Saharan Africa has relatively low capacity for risk managing the risk out of disease epidemics, mainly due to poor resourcing that can help with early detection, disease identification, and prompt response. The failure in the early detection and response to epidemics is attributed to various factors, including deficiency in the development and implementation of surveillance and response systems. Most of our surveillance systems rely mainly on traditional indicator-based disease surveillance, largely utilizing data coming primarily from health facilities. And even the use of this sort of data is also limited. Indicator-based surveillance approaches also face some other challenges, primarily data quality issues, inefficient early warning systems. They are less sensitive when compared to, for instance, event-based surveillance. They also miss information from populations that could also provide some sort of direction or insight or what could be investigated to detect something new or a potentially high impact disease. Indicator-based or traditional surveillance is underpinned by the integrated disease surveillance and response, strategy, IDSR, which basically utilize advanced technologies in detection and response for infectious diseases. In that sense, at the basic level of all these things is actually data use capacity. And over the years, data use and data processing has received inadequate attention. Any effort to address surveillance that doesn't consider disease data quality or multiple sources of data, data analysis, triangulation, integrating all the information in one place is going to basically fail to meet the mark. And happily, things like public health emergency operations centers are becoming centers, coming into the center of coordinating some of these data sources and ensuring that they are in one place. But the other aspect of it is capacity building for health workers, especially at the national and subnational level, which is currently missing, and efforts to ramp it up, is gradually scaling up. That said, there's a huge opportunity on the continent, for us to create a hybrid disease surveillance system, especially as everybody is working themselves towards the One Health approach, which is basically aggregating surveillance for plant, animal and human health, integrating community-based surveillance, digital surveillance activities, event-based disease surveillance, all in one place. It's also high time the region explores and adopts an integrated approach, creating this hybrid system, bringing traditional surveillance systems and their data, public information or data from public health laboratory, community-based surveillance data, research information, social media engagement, rumors, and crowdsourcing of information. I know that the NCDC at some point had a rumor register where they basically documented suspected information and investigated those reported on social media. And that is also feeding into the sort of, information that is contained on a platform like the Surveillance Outbreak Response and Management System, SOMAS. There's also the DHIS2 platform aggregating some of these efforts. So in essence, we need to come at a place where we are leveraging data and information coming from multiple sources without exactly limiting ourselves to the indicator-based platform that is mediated by IDSR at the national and subnational level. Things happen at the community level. Community informants have helped a lot, especially on a project like Avada, to report suspected cases that eventually turned out to be true, and an emergency outbreak, contained at that level. So primarily, what our conversation today is going to be focused on is basically the process or the pathway towards creating that hybrid system. How do we prevent outbreaks such as COVID-19 from happening again? How do we, manage historically damaging outbreaks like Lassa fever? I know earlier this year, we had an outbreak of measles in Kano. There's monkeypox hanging all over us, even though it's been disproven to not being an Africa-based infection, but somebody can easily bring it in and we could start suffering on something we are not prepared for. So that said, I'm going to dive right into this by inviting the next panelist to, present his opening remarks and thoughts. So basically, help us understand what have we been able to do so far, and where are we heading to, and are we in the right direction? Give us a national perspective, Dr. Agogo.
Good afternoon, everyone. It's a pleasure to be with you all. Thanks for setting the stage so clearly. I think you've raised quite a few issues here in terms of, how we should look at data systems, how data is collected, how data is used. You've raised some key points in terms of the framework. So maybe I will start with overall frameworks for data and how data, how public health security data is really managed in countries. So the guiding principles for public health data in the country is really the IDSR, the Integrated Disease Surveillance and Response System, which pioneered by the WHO, was rolled out in 2008 in country. And since then, Nigeria has done a lot of work in trying to make it the organizing principle and organizing system for data collection for outbreaks and for outbreaks in the country. Of course, the IDSR talks about indicator-based surveillance, which is the traditional indicator-based surveillance where we look at specific public health data, the health facilities, to look at thresholds to see whether we're seeing more cases. There's also case-based surveillance where, specific diseases, especially the high burden ones or high mortality, are identified and noticed and managed case by case, including Ebola, monkeypox, and some of those conditions. And then, of course, there's event-based surveillance, which is what you elegantly talked about, the use of non-traditional data to try and understand systems. Understand systems, community systems, and also to understand triggers and alerts within the community level. And there is increasingly a discussion to look at community-based surveillance, where you look at community systems to see whether alerts can come from primary healthcare systems, as well as community-based systems where you have individuals, non-health sector colleagues who work in the community, for instance, the village healthcare workers and so on. And I think one of the enabling mechanisms for this work has been electronic systems. So in the past, and largely in many places, especially in Nigeria and many other countries, paper-based systems were used to collect this data. But increasingly in the last few years, the introduction, especially since the Ebola pandemic in 2013, the country led the development of the SOMAS, which is an electronic-based system for collecting surveillance data. That system has evolved from being focused on case-based data and increasingly is now being used for other, beyond Ebola, now being developed to be used for Lassa fever during the Lassa fever outbreak in Nigeria from circa 2016. Models were developed, and subsequently other models have been added on for other case-based diseases. More recently, the NCDC has been working with partners to begin to develop and integrate event-based surveillance modules. For instance, you'd mentioned around Tatafo, which was developed by partners with NCDC that does media scraping, media mining at the national level. So looking at non-traditional media, both like social media handles for Twitter and for Facebook, as well as traditional media to extract surveillance-related data. We talked a lot about, with the work that was done by the MPHCDA using Avada, which is a community-based system to collect data and report suspected cases of polio, which Dr. Aban has been very key part of developing that system. And then, of course, going forward is to see how can all these systems move together. So all these things I've described have been largely at the national level. But we know from doing the joint external evaluation of health security in Nigeria, with the implementation of international health regulations in Nigeria, that the weakest link in a country like ours is not what's happening at the national level, it's the subnational data systems. Can we do the last mile? Can the data come from the last mile if we have a suspected case? And all these I've described will not work if at the subnational level things aren't functioning well. And our colleague Suleiman will mention the kind of work they've been doing. The other thing that also threatens the ability to report effectively are vertical fragmented systems. So integrating systems where people can make decisions based on looking at data perhaps from various sources and integrating the data decision-making process is very critical, and we hope that part of the work we've been doing with Chinedu and co from eHealth Africa, also with the NCDC, has been trying to get a better grasp and methodology for doing this effectively. I'll just end by introducing some ideas that are beginning to evolve about how we might improve data use. So Resolve to Save Lives has been working at the global level and choosing it and piloting in Nigeria the concept of 717, which looks at, in the past, looks at a system for including doing performance management and bottleneck analysis with a systemic view of outbreaks. So in the past, we had to rely on when an outbreak occurs, we do either an after-action review to see what happened in the past, and in that process, look at a timeliness matrix, time from when the specific outbreak happened, when it was reported, when the lab diagnosis was confirmed, when you mounted the response. And those timeliness metrics were not always used. The other IHR M&E mechanism, of course, has been the JEs, which countries report themselves, as well as the SPA tools, the annual reporting by state, by countries. These are the other mechanisms for understanding how well systems are. The M&E systems were developed also for Idsr implementation. So you have various completeness and timeliness metrics that you report. The future, like I said, is around looking at the 717, which we've been piloting, the idea that within 7 days, we should look at how the various systems that need to be there to identify an outbreak within 7 days, to report from the subnational level to the right entity in 1 day, and to mount an effective response within 7 days. So this is some work that has come from really trying to understand data and how data is collected at the PEOC level. Another key concept we need to also think about is the change in the joint external evaluation tools. So that this is now the third iteration since 2005, and there are more changes in terms of how, and explaining a bit more about the expectations that countries should have to develop integrated, interoperable surveillance systems. So not just systems that work for human health, but systems that align human health, animal health, environmental health, so that you have a more holistic approach to identifying disease threats. And then one final concept really is the idea of subnational strengthening. So we've worked with the NCDC and with colleagues to look at doing this same kind of national level assessments at the subnational level to look at what systems are there at the subnational level. Can we help strengthen the One Health approach and make sure that at the state level, in all the states, that the EOCs that NCDC has established can become hubs for data integration, hubs for data analysis, and hubs for appropriate decision-making at the state level. So I'll stop there and allow other colleagues contribute. Thank you very much.
Thank you, Dr. Agogo. Quite an extensive repertoire, and then the 717 idea is actually something we're going to come back to at some point, seeing exactly some of the timelines that we've created for detection, response, and what have you. But let's check and see what the perspective on the continent looks like. And I know Dr. Aban has been involved a whole lot towards AFP surveillance, and eventually resulted in Africa being declared a polio-free, Africa being declared free of wild polio virus. And it would be such an interesting perspective to see exactly how that work culminated into that certification, but exactly what we can readapt from that effort into some of the mainstream surveillance efforts, especially for some of the reportable infections that we have and those that we want to set up for eradication. Dr. Godwin, do you want to share some of the things that has happened on Avada and then how that exactly relates to strengthening local level surveillance system? I'm looking at how interesting the community level surveillance for Avada worked. That exactly ensured that we could build on paper-based reporting, and then scaling things up a little bit more by bringing more people, or basically having more eyes on at the community level to report issues. Can you share some of your perspective in your opening remarks?
Okay, thank you, Chinedu, and quite an interesting one there by Dr. Agogo. I don't know whether you can hear me well.
Very clearly.
Okay, perfect, because it's showing the low bandwidth here. So I'm somewhere in Kenya, in the middle of a greater Horn of Africa response to food insecurity and drought. This used to be an area that was focused for food agriculture organization, but over time we're realizing more and more that health is impacted by food insecurity and things like that, which is also leads us to the conversations we are having. Community-based surveillance is the cradle of, if we're talking disease surveillance today, we cannot take out that. You have to look at what is happening at community levels before you can have that overall general perspective at the continental level. And you have mentioned Avada. Avada is not in all countries in Africa. So giving a global context would be a great disservice just using Avada alone. So I have pulled together like a couple of other interventions that are running across the continent, and generally just looking at what can be done different, or how do we leverage the systems we have. And importantly, I'm excited that everyone is mentioning the One Health approach, which focuses on zoonotic disease, where more and more it's looking like that's where our problems always come from. The major outbreaks, the pandemics, they will always be coming from animal to man transmission. And that's quite an important aspect to look at and converse about. So I do have a couple of ideas, also leverage on what my co-panelists have said. First of all, I want to say that there are over 100 outbreaks that happen in Africa on an annual basis. And of course, Nigeria being the most populous would probably account for between 50 to 60% of those outbreaks that we record. And more than ever, we're always excited when Nigeria leads the way in terms of surveillance reporting, in terms of IDSR, in terms of event-based surveillance. And I'm glad that this has come up already in the conversation. So I'll just quickly share my screen, and I show you like a mind map of what we think about this particular conversation. I'll be brief so we can quickly understand. I think talking always doesn't quite get it all the messages across. Sometimes you might just need to showcase something simple, and people will really latch onto it and understand. So I don't know whether you can see my screen.
Yes, it's visible. Please go ahead.
Okay, great. So we have over 100 outbreaks in the African region, and it gives us concerns a lot. But the important thing is that somehow we're getting them reported, and our average time to detect has dropped from 15 days to about 5 days on the average across the continent. I didn't say respond, I said average time to detect. And that's because of more of event-based surveillance than the IDSR that is supposed to be our best tool. But we're hoping that we could augment some of those limitations around IDSR. Dr. Gogo has mentioned some of them, but I'll just quickly run through. So in optimizing our subnational use of data, we always think about community informants, finding that case, let's say COVID in this case, detecting it and informing us. And there could be a couple of ideas around that through the internet, through SMS, and through EIDSR, as the case may be, DHIS2, ESOV, as you mentioned, which is more of a surveillance thing. SOMAS, this Avada multi-disease just rolled out too. All of this sends an alert all the way to facility and district level. And that alert comes to us at the regional in Afro and at the global level. But we expect that the district level, which has the IDSR 001, will investigate this. And that could be a problem sometimes, because that loop, we may not know whether the IDSR has reported all the cases, because they deal with, IDSR deals with suspected cases and not confirmed. So once this is investigated, case-based surveillance normally kicks in there. And that's where the strength of platforms like SOMAS that has integrated lab and case-based surveillance, which is a major challenge in optimizing data use. SOMAS has overcome that by integrating the lab network with what is done at case-based surveillance. And that confirmed case comes all the way to us and to the national level, and mostly we have data pipelines that lead to a data warehouse, and that's where I want to emphasize over time. So us at the regional hub, we see all what is happening thanks to technologies that are leading real-time data into the regional hub. But sometimes it doesn't happen. In lots of African countries that have paper-based systems, and it takes about 60 days to get any information across. So the context here, I'm looking at Nigeria and how effective. And because of this, we can now plan for vaccination, as the case may be, respond if there's an outbreak in the case. And all of our decisions, see how important it is for getting this right data, to assess, to plan, to train, to sensitize, to write guidelines and support countries. All of it comes from that data. And even all our modeling and estimation for COVID and all of that comes from the fact that countries give us data and then we can support them. All right, so this mind map just helps you put in perspective what happens at national, regional, and if you look at it, where can we optimize, which we'll be talking about, is through our data pipelines, interoperability, and also the tools that are in country. How do we improve them? So these two major things are key for us looking at the regional level. Very, very important keys that we can make changes about, and that's probably what I will be talking on later. And then maybe just lastly to leave you with this, I know you know a bit about event-based surveillance. I just talked about indicator-based surveillance. We have what we call the EIOS, which is looking at epidemic intelligence from open sources, and which is an African Regional Office platform that is the equivalent of Tatafo, that picks up, scraps data from different sources, from social media, from anything that's has been sent out there, and then we can easily filter and start our very first basis of knowing that there's an outbreak there, or there's a disease that has surpassed the threshold, and then we can start our whole response system, and that is based on event-based surveillance. So I just wanted to put these two things in perspective. I know it will drive our conversation as we go further. Thank you.
Well, this is quite some very in-depth thinking, and it all comes together now and exactly seeing how things link together. Thank you, Dr. Aban, and I'm going to be coming back a little bit in terms of how that interoperability works and exactly that data flow, and exactly how to encourage data quality. But before then, let's go to the local level, or let me say the subnational level, to exactly see how things work at that level. Seeing exactly the data flow from the community level up to the state and the national, and perhaps at the regional or continental level before it goes global. And Suleiman could share some of his thoughts or ideas in terms of how they've been able to coordinate some of the most challenging disease detection and response efforts at the state level. Suleiman, can you share with us what your thoughts are with regards to coordinating some of the most challenging scenarios, detecting outbreaks, and then coming together with your colleagues to provide response, and also looking exactly how to capture some of the things that happen at the community level?
Thank you very much, Chinedu. Thank you very much. So first of all, I would like to just look at as have already been highlighted from the initial introductions at a subnational level. As we all know, Kano State is the state with the high number, is a populous state in the country. So being that we have at least a total number of 44 LGA with more than 160, with more than 774 wards. So which really show that we are almost part of the state that have a high incident, high outbreak in the country. As we all know, the patterns and the surveillance structure is already been established from the Idsr normal guidelines. as we are all know that the normal surveillance structure for mitigating or responding to those outbreaks is basically starting from the community. So those structure, it has already been established at the community level, which is a normal IDSR structure, starting from community informants, facility surveillance focal persons, LGA, GSNOs, as well as going to the states. So looking at all those number or data follow, so we need to have to first look at how are we streamlined, how are we coming to make all those diseases or report or data from those highly listed facilities or surveillance structure. So the first thing we will just look at how are we working with the old structural systems at the community level. So we first look at the systems is already established. If you look at the event and community-based surveillance, we are trying to see that all our people at the community level, they has a basic knowledge of how to respond, how to report a disease from basing from a community level to the facility level, as well as then up to the LGA level, then upward to the state. So basically, most of our community informants, the states has introduced a way of making those people be visible, be functional, to see that we are always trying to see how all the reported or suspected cases that may have potentiality of causing outbreak. So we try to map out and we try to see how all those people at the lower level has insights, how they report a case, how to identify the diseases. So looking at that, states Ministry of Health or state primary healthcare management board. So at the state level, including all the partners who are opting, working together as an approach in how those information at the community has as easily accessible to the LGA, then upward to the state. So looking at that, we are trying to see that timely reporting from LGA is the basic line of aggregation of all those missing diseases for easily responses to the reported case at the community. So we see at the community level, we're trying to look at those CBOs, that is community team leaders, community healthcare services, how those people, they work together with the community informants, and then they will easily detect a disease and report to the state. So as a populous state in the country, at the state level, as all this data has followed, we are always trying to see how those information comes in timely basis. So looking at that, we are always, we institutionalize a disease weekly data harmonization meeting, which includes all the responsible partners at the state, stakeholders at the various sectors, including One Health approaches, will stick together. And then for us that we always equate with the data from the lower level, we disseminate that information with the all responsible stakeholders during the weekly data harmonization meeting. So this will really help us, but so far some of the challenges it really comes, which I'm sure during the data harmonization meeting, we try to capture most of the information that may have related to making an unaccessible or delay in response to diseases or reported cases in the community. Looking at the Kano states, we have different diseases, different outbreak, which is really need to quickly respond to it at the from at national level. So the states has, after all those stakeholders meeting, we are trying to see all our 44 LGAs has the local RRTs. So the local RRTs, that is, so that's RRT people, that the people who firstly informed, and then once if there is a reported case at the facility, we'll make sure that those people at LGA level, they have easily access information directly. They will respond to the outbreak, the reported cases. So looking at that, we are not even strictly stop them from following all the other reporting and control system. We strictly make them accessible directly, strengthening their services and activities from the community, and then they will have DSN have access, and it has all taking all directive of making a response to all reported from those communities at community level. So which really help us to see that all cases that has been reported will be will easily have assessing and then responding to that disease at the community level. So the problem.
Yeah, just pull your thoughts up so that we can bring in additional questions. Yeah. Okay,
sorry. So most you know the responding time, we really appreciate how the states at LG level we have the RRT, and then we initiate EPR committee at the LG level to see how all if there is need for other additional responses. How we mitigate the outbreak. I think there are many things which is already written from the, you know, I have some screen, so maybe in the next other part of the presentations, maybe I can share my screen with other people so that they'll see how all we trying to see how we follow the responses and the data follow for the for response on outbreak in the in Kano State. Thank you very much, and over.
Thanks a lot. And I think we are going to go right into the centrality of data and disease surveillance. And then probably we can come back to that presentation because some of the comments you made were quite very important and essential. But let me first, let me go back to Dr. Agogo again. Let's interrogate data, right? It's overstating the value and the importance, right? But I want to look at if the current flow and availability is adequate. Is there something that is missing? What else can we build on? And how exactly is or what is the dimension of the data capacity gaps that we have, especially at the subnational level and at the community level? Could you share some of your thoughts and perspectives?
Thank you. I think there are several angles to the question you've asked. First of all, you've asked whether the data being collected is adequate or whether there's a lot of data. First of all, there's a huge amount of data that is out there, huge amount of data. But a lot of the data is still paper-based, so it's trapped in paper, and therefore there is no access to the data. And for that reason, it's very difficult to access and make decisions. You also asked about data pipelines. In terms of data pipelines, there are lots of data sets that are available as well at the facility level, which people can access. In terms of to specifically talk about that, you can imagine that the data that is collected when people go to a health facility, even as we speak today, virtually every public facility you go, they will still take your card. and they will still try and find your paper card and then give it to you, and then you go and see the doctor, then the doctor writes in it and they give it back to you. And then somebody at some stage does some summary of that data and provides like a monthly summary form of how many people attended the facility, and in some specific cases, monthly summaries for the specific diseases of interest. So we have systems in place for AIDS, TB, malaria, where somebody does those summaries and compiles them in a monthly summary form that is from the daily entries that are entered into a daily facility register. So you see the doctor is summarizing to a facility register, and someone has to manually take the data from the facility register and summarize on a monthly basis into a monthly summary form. So that data process is cumbersome, it's prone to errors, and is dependent on individuals to do it correctly. And sometimes these same individuals are meant to do it for the HIV program, for the TB program, for the malaria program, for Lassa fever, for the RMNCH. And so you can imagine that, this is a burden, and the human resources at the facility level is very limited. So that's the thing in terms of the data pipeline from the facility level. And this is like at the PHC. In tertiary hospitals and in secondary healthcare facilities, this is not as well established. So there's episodic care, there is no linkage. In terms of the quality of data, what I just described to you, obviously, is prone to error. And we know about GIGO, garbage in, garbage out. So if there's any problem at some stage of that data collection from the data that is entered to the summaries, then it affects, the quality of data we get. While this is not necessarily while these triggers can affect the global data, it's even more important about how this poor data collection affects the individual. Most individual patients don't have access to any of their health data. And for that reason, even their continuity of care for the individual is also a problem. I mean, as a primary healthcare physician, I kind of see that as the starting point. So while we want the health data to make these bigger decisions, on the face value and the face-to-face level with the patient, it's important that the data is available for that patient longitudinally for him as an individual. And then at the program level, longitudinally, that can help you make programmatic data changes, as well as data that can be used in healthcare financing, in healthcare planning, and in making adjustment, and in also healthcare resourcing as well, about human resources for health, and so on and so forth. So there's this lack of that systematic view of data. So one of the pieces of work we did, we look at building, what would it take to build a comprehensive surveillance system, for instance? Just look at all the data sets that are available, whether it's from these disease-specific areas, or whether it's from event-based surveillance that Dr. Aban eloquently talked about, or EIOS, which we also work with, to kind of create a proper holistic view of what the data systems are out there and how we can create dashboards or create data products that are useful. And I think that's some of the work that was done by eHealth Africa, looking at the state level, at the state EOC levels, what kind of data products can be made, and when you create, and what data products are needed by my colleague Ilyasu and his colleagues at the state level, by the Commissioner of Health, by the PEMSEC, by the Director of Public Health. What are the data products that need to come out of the data? So we already have, in summary, we already have a lot of data. We just need a more integrated approach to looking at the data. Nigeria has the National Data Repository. It's a huge opportunity to building DHI, pulling DHIS2 data and data sets from various disease programs to help us plan and implement programs more effectively going forward. So I'll stop there and let any of my other colleagues, to also to contribute.
Yeah, excellent. I recognize that maybe next question cycle, we'll probably look at the PHEOCs as a data warehouse, for that sort of, or basically that middle point that aggregates everything and also supports with the analysis and dissemination. But let me find out from Dr. Aban if there was any value in targeting and focusing specifically on AFP with regards to wild poliovirus eradication, and exactly how they solve the data quality issues, seeing exactly how things basically transited from paper collection method, leveraging on the indicator or traditional based surveillance system and then transferring it into their, leveraging the EIOS platform he talked about during his presentation and also the event-based approaches. I agree also, I believe also that there are some perspectives that we never got to see, from our, participation in the implementation of Avada. But I wanted to see, based on what Dr. Gogo mentioned, if there's any value in isolating AFP surveillance and then just focusing on it and throwing every available human and financial resources in terms of getting it under control. What are your experiences in that level, and how does it exactly, bear some sort of case that could be replicated, especially as the platform is now being converted into a multi-disease reporting tool?
Okay, yeah, thanks, Chinedu. And yes, you're right. There was a concern for the public health space itself that at some point it looked like the rider for, hello?
We can hear you.
Okay, so that the rider for all surveillance, disease surveillance at facility level and even community level was AFP, polio surveillance. But over time, I think in the past 3-4 years, we started having an integrated approach. You can't visit the facility or visit an informant without asking questions around the other priority disease, like meningitis, measles, yellow fever, and the case. So active surveillance of polio or AFP as a case maybe, has been a strong basis for other case-based surveillance and other disease in the region. So that has been what has been used for providing the very basis for the integrated approach at the regional office. So for the African region itself, we understand that polio had provided that basis, and currently we are leveraging it for the full spectrum of other vaccine preventable disease. But the interesting thing is that the emergency preparedness and response aspect of the region also realizes that the supportive supervision being done there shows us a spectrum that tells us how far are we covering districts and provinces across the region. And that showcases other things like surveillance gaps, showcases where we can apply things like precision public health, exactly where we would focus our vaccination or exactly where we should ramp up visits. So separating polio alone would be a proper waste of resources and a great disservice to the African region itself. So it's been like a rider for the past, like I said before, it's been like a rider for all other, or entry point for all other interventions across the African region, and this is exactly what we're doing. However, we still noted a few challenges around data use, and that is irrespective of what disease we are looking at. So I don't know.
Your video and your voice are coming through very well, so you don't need to worry about that, unless any other person will, but I can hear you loud and clear.
Okay, perfect. But unfortunately, I can't see anything on the screen now. I think that's a technical hitch.
Are you trying to share your screen?
Yes, I wanted to actually talk about a bit of what we've realized based on the experience from leveraging AFP surveillance resources for COVID-19 surveillance. And that is quite an important aspect to look at, especially when we are considering all the integrations. And today we're talking about data use and optimizing a sub-national case. But maybe just to say that some of the challenges that are common to all the systems, irrespective, is government, how would I put it? Government ownership, all right? when governments do not take leadership over this, it becomes very much of a struggle to get it. But in the context of Nigeria, very glad to share that NCDC and between NCDC and NPHCDA, we do have some very, very good surveillance-rich products, vaccination, and all of that. And that's also what has shown in the COVID-19 response for Nigeria. It's been quite very impressive. And that has shown results in the fact that we didn't have, our systems were not overburdened, although there might be other factors too that could actually be a reason for that. But importantly, I think it's understanding the context of COVID-19 and all the challenges we face with data use. It also applies across all other diseases that are being under surveillance in the region per se, because COVID-19 challenged us and showed how weak our systems could be and how not very responsive we are, and having to tweak here and there. But the important thing also is that we have learned a lot. We have known that accountability, vaccination has to be also planned in line with very good surveillance practices to actually ensure that disease surveillance is covered on a very, very basic level, from the communities to all the way to the national and even higher up. So I'll stop there, and hopefully our colleague will take us into what it means at the very, very ground level, because I am just talking regional and global level here. Over.
Yeah, we want to have that perspective. And just to set the stage for our audience, after the next cycle of questions, we would open up the line for question and answers. So you can start documenting your questions, and then Suleiman is going to speak, and then I will treat, or we will treat the issue of timely detection and response, and then merge it together with the issue of gaps and capacity strengthening, focusing specifically on what we need to do and how we need to, come good to be able to detect issues in a timely manner, especially using data, and then driving it further down in terms of key action points in what health systems at the regional, national and subnational levels need to do to be able to get a hold of these things and ensure that we can, promptly or proactively detect some of these things and get everybody who needs to take action to act. Because I believe specifically that this is actually the critical way for us to stem the tide, or basically strengthen our emergency preparedness capacity. And that would also lead us into zeroing in on the 717 methodology that Dr. Abdul mentioned about. So without much ado, Suleiman, we have about 23 minutes or thereabouts to go. So Suleiman, if you can give us some of your thoughts around exactly the data capacity structures and challenges that you have with at the state level, and then how we can basically use that to strengthen what we have and to make your work easier. If you can share your screen, just take it away. I know you wanted to share something.
Okay. Yeah. Okay.
Yeah, share your screen at the middle. You can just click on it and then select the file. If you're otherwise, yeah, if you're finding it difficult, send it to me and I'll put it up.
Sorry. Okay. So I'm sorry.
Maybe you can just speak to the slides. Yeah.
I can just speak on from the slide, not directly from the slides. I think this is very, very important question, because we are part of the actually fearful that we really have need to adjust some other very key valuable things to in order to make data capacity, and then for early response of diseases at lower level. Number one, the first challenge is I know, which is already been highlighted from the others, colleagues. Our most likely challenges at the community level is from the facility. Let's just start from the facility level. Actually, since from the data entry at the facility level is the worst challenges, delay in reporting, and the data is not actually, we need to have a streamline, we need to have a quality way of facility people or as well as of community people who have been giving a qualitative data at lower level so that the data which will speak, and then we'll see how those qualitative data at community will help to early response for policymakers to see how we are going to respond to a disease at community level. So that data quality is the worst problem that we really have. Then we need to have at least, looking at the worst problem at the facility level, we have to look at how are we going to strengthen in that. So number one, we need to first look at we first have to look at the record systems. We have to review how the data is being entered at the facility level. Definitely, we have a lot of problems, which really we as surveillance structure that we really know that people at the community, they will not make use of all those, our ideas are 001, and then as well as 001, to make it very feasibility to be used at LGA level, at the state level. So sometimes the data may come, which has not been captured, all the details information. That is really what we really even miss. It even affects Kano State during that cholera response in 2021, which we have more than 224, which we have more than 12,000 cases in Kano, or cholera cases in Kano State. But due to some missing variables, so it really affects us to be having vaccinating our people. So definitely we need at least at this fora, with all those coming up, I'm sure we have a lot of development looking at the partners who are supporting states to making us have a dashboard, making a data quality at the state level, but at lower level is the worst problem. And definitely we need to streamline because so much is not taking care of all the facility and the LGA. So I think we need to start looking how we are going to see all those data quality start from the lower level upward to the higher level. I think this really helps us, and it's really help the states' healthcare systems, and we'll see. And then the next from the data in coping with the national system. If you look at for the AFP detections, in most cases. We follow up with all those CBDTV that we already have in the state, and mostly part of the missing challenges, it is almost all over circulating over all our data is being copying in the state. You see, for the all data quality is the worst problem. And then it even affects not only facility, generally, since from the LGA down upward to the state, where we have a huge of data, like for the COVID-19 data. We have a lot of data which is already written, but in that world, with the coming of all those new way of interrupting of data, making the data feasibility, with the works of in-house that support the state to make data very well visualizing. We work with the we use so much information formats. It really help how to strengthening the whole system of data flow, but at least our citizens need to be looking at all those lower level, and then we come to create a dashboard which really help the states for making easily people to see, giving them easy assessing feedback. And then for some other partners, like for our One Health approaches, we need to have at least dashboarding how we link between health, environment, and all other things. Because here in Kano, we are at lower level, most of our diseases have particular to the environmental sanitation. So definitely we need to start looking how those data from environment, from agri, we co-opted together to make us, to be accessible, things from lower level that make it very quality so that we'll take appropriate action take appropriate action in a response to if there's need for taking an urgent response. I think it really help us. I think this is my thought for the challenges. I have many things I need to show on the screen, but definitely this is already which is been highlighted from the screen. I think maybe I will stop here because I know the time is not in our midst. So thank you and over.
Thank you so much for your perspective. I'm sure there'll be enough time to, if not on this section, maybe on the next cycle of the section for us to discuss some of these things in details. I'm on the home run right now, and the last topic I want to discuss will basically be merging two concepts together. First, the concept of timeliness, which is basically ensuring that we can proactively detect potential outbreaks and provide the necessary action, take the necessary actions to, mount a response activity to prevent it. And I know that Idsr has set out, specifically alert and outbreak threshold. So at the alert threshold, you basically have a number of cases that needs to be reported or achieved for you to basically get all systems at alert and then get them to take action. And then there's the number of cases that you need to get to, and then it becomes an outbreak. In that sense, I know that there's a scientific approach called the 717, which is basically trying to help us understand the number of days it takes to detect, number of days to notification, and the number of days to response. My next cycle of questions will basically interrogate to see what aspects of our existing systems do we need to strengthen to be able to effectively implement this new timeliness approach, and at what level do we have those sort of responsibilities? After this set of questions or answers from our panelists, we will throw the floor open to all the attendees to ask questions. We need to get this wrapped up in the next 15-20 minutes. So Dr. Gogo, you will go first once more, and I'll probably see if we want to capture your thoughts in 2 minutes. Then we'll go to Dr. Aban and then Suleiman, and then see what questions we can get from all the panelists. Over.
Okay, thanks. I think to make that easier, I did put a link in the chat, and I'll put that again. It's a Lancet paper written by Tom Frieden, our president, on the matter of 717. So like I said earlier, it's really an organizing framework to see whether we can work on and how effective our preparedness and response activities are. Like I said also before, for the IHR implementation, you had the after action reviews, which is really a process of saying, well, did you do it right? And the idea of 717 is to have something similar to the principles of 77, 95, 95, 95 for HIV, where you have a target to aspire towards. And in the past, for reporting data, it was timeliness and completeness of data reported from the subnational level to the national level. And more recently, with pilots in Kano and Kebbi State, completeness from the local government level to the state level. And also the idea of zero reporting, encouraging zero reporting. And Suleiman already talked about the IDSR documents from 001, 002, 003, and how these data sets can be used better. And final thought around this is, it's a very early stages. And I think that is something that potentially in the future, we can build a system that looks at data and data use, data collection, data use at the point of collection. So at the health facility level, are we having more malaria? Are we having more cases of X, Y, Z? And also at the local government level, which should build capacity level, extending to the whole data cascade you talked about. And then there are also requirements for data exchange, data exchange and protocols for as well as regional and globally. So those frameworks need to come in. The data hub that our brother and friend and national and former DG of NCDCs were seeing, the data hub in Berlin will be instrumental to this. And then finally, the other idea in terms of for data systems is really also beginning to think about using electronic data systems, interoperable, interconnected data systems that make it easier to collect data, to visualize data, to summarize, and automate the process a lot more. I'll stop there so that my colleagues can also have a few words. Over to you, Chine.
Yeah, are we seeing some of these perspectives at the regional level, Dr. Aban?
Okay, yeah, thanks. I think so. On the regional level, it's a lot easier for us because we are collecting data from countries, and it's easy to see if a country is not doing something right. All right, we are able to generally give feedback to the country. A couple of hours ago, we had this Idsr evaluation from the African region, and generally just giving feedback to all countries involved. And one of the things I noticed, let me just quickly share this, could be a talking point for colleagues, is that across the region, we're having only 2 countries that are meeting the timeliness of reporting based on Idsr, and this is over the past 3 years. I know COVID has not helped us, has really hampered or placed further burden on the health systems and generally reporting. But when you see this, you get worried that our time to dictate might not be optimal because we are generally not reporting well. Yeah, and that's because of the lack of systems at the very grassroots level that can aggregate data from community to facility all the way to the top. We don't have it everywhere. Like a colleague also said, SOMAS is there, but SOMAS is not everywhere. So we're having gaps in surveillance reach or where we're getting our report, and that's what we need to try and find solutions and block those possible gaps and improve reporting. But I just remember that I needed to share this, and this is the challenges we have around data use per se, and it's broken into this four linkages: data access, analytics, and actionable insights and capabilities. Yeah, and that's where we start talking about things like human resources. We need to train more people, and maybe just to leave on this thought that we need evidence-based leadership, and that can only come from country teams, and that's one of the things we're focused on at the African region. We want to try continue to support countries to show leadership in this, improve their own systems. We're quite very open-minded. That provided the system is interoperable, allows us to connect to it. We're very, very excited about doing that. And one of the things we are hopefully going to do in the next couple of months is connect to DHIS2 locally, to Nigeria, and also connect to SOMAS as a whole, so that as soon as data leaves the point of entry, we would be having it at Afro. And that would mean that we could possibly give feedback around the alerts, allow the thresholds and all of that. We'll be on top of our game, and that would definitely reduce average time to respond to on the whole. Over.
Excellent. Thank you so much. And I hear you quite clearly, which is the overall effort is actually to, condense or basically reduce that time to detect. But let me go to Suleiman and find out if, I know there was a measles outbreak in Kano earlier this year, and the data products that we developed in partnership with the team in Kano basically helped in giving us some sort of insights in that regard. Do you think that you are now leveraging the sort of support you need to get this working, or if not, where do you think there's a need for additional strengthening to be able to ensure that you can align yourself or basically reduce the time it takes to detect an outbreak, especially at the community level?
Okay, thank you very much, Shinadu. So I think with regard to that, I will not, my senior colleagues has mentioned as much as they do, but we get really at the state level, we do for the support we have got from the programs that you have already been at the state level. At the state level, we don't have much. We have a lot of improvement where we capture all our information and we make it very accessible to the community. But some key challenges, issues, which we really need to at least we need to increase the capacity of our networking systems for data follow from our community to the states. So sometimes if we are fortunate, as the first support we got from your programs, definitely if we have a lot of time that we integrate those, we cascade or integrate those high quality assessing, keeping, screening, cleaning of all those data before coming to the state level to really help us to see that if the data to come, it come clean from the community level, it really helps the state level to make very well accessible. And then at the state level, we need to increase time bounds for reporting from the community to the state. I'm sure. And then there is need for training, to retrain, to have more other capacity building, which I'm sure we really have a lot of changes. The projects that already give us those opportunities at the state level, it really helps us. It really make state level, it changed the whole systems of reporting from the community, from LGA to the state. But how about the community or from the facility to the LGA? If you see our timeliness and completeness, it really changed with your project that would really emphasize on how we make our data very clean and we visualize it. We give them forward, we give them feedback within a short period of time. Unlike before that, we have to wait till maybe end of the month. But in a monthly basis, they easily have access to their input, to their reported from the LG, and they have feedback. So I think if you have continual getting those, if you continue receiving such support, to really help us to see that all those things really go in order. So I think I will not say much here because really we need to at least streamline and to have a good access of how we make those data accessible from community to the state and state to the LG. I think there are other many things which I'm sure time will not give us to state it, but we really make use of the support that we got here. But I'm sure with this, if the support has stopped just like that, so it may end up going back to zero marks, because at the LG level, at the community level, they have those issues of missing barrier and all those other things. I think that maybe if you have much more time and to increase all their projects, it really help us. There are many things that we may be jotted when you come to assess. Thank you very much, and over.
Thank you so much. We are almost at the time that we set out for this. Unfortunately, it's likely that we're going to push it a little bit further down, but I will do the most I can to wrap it up quickly in respect to people's time and schedule. That said, I am going to leave the floor open for question and answers. If you have any question to ask, please kindly raise up your hand and we would unmute you to ask your questions as briefly as possible. State your name, country where you're speaking from, or your position, and then perhaps direct your questions. Otherwise, we will just appoint any of the panelists to answer. If not, also use the question and answer box to ask any questions that you have, and then one of the panelists will respond. We will do this under 5 minutes so that we can get the final thoughts from our panelists and then wrap up the section. If there's any question, we're going to take it right away. I'm trying to see if there are any hands up. Okay, I am on this. My perspective would be to suggest that this has been an interesting section. If you have any, okay, I see one person's hand up. Help desk, can you help unmute the person so he can speak? I'm trying to. Okay, Victor Obodo, yeah, please go ahead.
Just good afternoon. This is not Victor Obodo.
Victor, please go ahead with your question.
Okay, my name is Duke Ogboko, so I don't know. I raised up my hand. I don't know
Please
if it's
go ahead and ask your question.
Okay. Okay, like you said, we should introduce ourselves briefly. I am Duke Lawrence Ogboko. I work with Alive and Thrive project of FHI 360. I'm the Senior Technical Advisor, M&E. And I think this presentation was so interesting from all the presenters. And I don't have question to ask, rather is to make an impulse to what has been discussed. Because from all looks of things, I found out that the challenge is not at the top level, but probably not even at the middle level, but at the lower level. So to say that the AGA, the communities. So my suggestion, which looks in line with like that of Suleiman, is to really strengthen the lower level in terms of capacity building, and at the same time, to understand properly the use of the gold standard, which is paper-based, because there are a lot of electronic systems that have just been presented that are in the near future going to interface by interoperability. So I think the crucial thing at the local level or community level is the gold standard, which is the paper-based. So it needs to be properly streamlined, capacity built on it. Since I use a means of the SMS or WhatsApp, because they may not get hands to training facilities like laptops. All of them may not have laptops. I mean, they have it. They may not have network. Yeah. But it's much more easier to have something like network on telephones. So they can use that to relay their information up to the next level. So I think it's a good presentation. Well done to everybody. Thank you.
Thank you very much. I know that there's an SMS-based reporting system that is being considered as we speak, and should be rolled out. Avada was actually SMS-based, and I know that being able to cascade that sort of technology at the community level is currently ongoing. There's a question from Halima Abubakar, and she's asking, how can we improve or strengthen event-based surveillance at the community level? I want to direct this question to Dr. Agoga. I know that this is actually your forte, so maybe you are the best position to give us a stronger perspective.
So thank you for that question. So quite a few things are possible. First of all, just some information. So I know that the NCDC and the MPHC, they are actually working on a national guideline for community-based surveillance. So that's going to be one more data set that will be available. In terms of infrastructure for event-based surveillance, some of the key things that happens is really moving, there are technologies that are available to provide data sources. So there's, like I said, the community-based surveillance and Avada that will come from there. There's the data, there's the social media mining tools like EIOS, which Dr. Godwin talked about. We work with the US CDC, NCDC, and the WHO to implement the EIOS. And then there is even something local called Tatafo, which means I know normal Tatafo, that's a software document that has been developed that looks at Twitter and so on. And the idea within the NCDC is to begin to look at how to aggregate this in an event management system, and there's something called CITA where all these hits can be aggregated, followed up, monitored, proved, or set aside. So it's all these data sets being aggregated into an event management system, being assessed using, at the moment, trained individuals, in the future, perhaps AI, and then making a decision or determination whether the alert should be followed up or whether it should be set aside. Outbreaks have been determined even using this system. Over.
Okay, thank you so much for that quick answer. And I am just going to also mention in respect to Mr. Wodo's question that we've also used SMS-based mobile entries for our EIDSR project in Sierra Leone. Adeola Akintola is asking, how do you reduce data falsification at the local reporting level? From the data Dr. Godwin presented on reporting timelines, how can Nigeria improve? Dr. Aban, let me push that question to you. I know that you've dealt with tons of information from various countries across the continent. How do you do this sort of isolation that allows you to, improve the data quality that you have, remove falsified information, especially, at the local level where there could be quite a lot of things affecting that?
Okay, yeah. The uniqueness of Africa is things like that. We have falsification, we have validation issues. So I'll probably just share an experience from one of the platforms which I helped develop, and that's the supportive supervision. We have over 10,000 health workers conducting supportive supervision across 45 countries. And one of the key things we used to have was that people would sit at home and fill that data and submit. It would mean that they didn't conduct the supportive supervision. So we added accountability at the base of it. Collect GPS when you enter the facility, collect GPS when you're leaving the facility. Take a picture of the evidence. You say, for example, you want to check out the updated monitoring chart. Do you claim that there's an updated monitoring chart? So take a picture of it. So that photo validation alongside collecting your normal data reduce falsification of data. So in the case of Idsr and all other data, there's always this thing around placing validation mechanism at that point of entry, and also having some level of supervision that happens, that someone comes around to check once in a while without warning. And that creates a system that people become accountable and also understand the implications whenever they falsify data. This is things that leads to actionable insights. If you get it right, it would mean that you have strengthened surveillance, and would mean that we would also respond on time. I think that's the much I can add on that, especially coming from my own perspective.
Thank you so much. And unfortunately, this is actually about the most we can take from this section. I want to, however, give 1 minute to each panelist to summarize or wrap up their thoughts. And then David Aban is going to then come up with the closing remarks, and then we can adjourn this webinar. EHA will be providing a link to the recording for this section. And I don't know if Dr. Aban can oblige us some of those interesting slides. We could add it as part of the materials being shared to participants. That said, let me start with Suleiman. Just 1 minute to share some of your closing thoughts, and then we can go through Dr. Agogo and then Dr. Aban.
Okay, first of all, I would like to thank the organizers of this very, very important webinar, which is really actually give us insights to discuss with the senior colleagues to hear from the different perspectives. So once more, I really want to make this forum to be highly interesting, to be making it close, so that we will be assessing and we will be contributing toward development of surveillance systems, as well as this outbreak in the country. And lastly, I would just like to add more to see how stage aware it is going to be implemented at the lower level, because it's always within the state level. So lastly, I will stop here. So I really appreciate you, and I will make everything. I will be aware, I will be available once if any opportunity comes, and to increase the capacity of our LG, our surveillance system at the LG level, as well as at the state level. So thank you very much. I really appreciate it. I'm over. Thank you.
All right, Dr. Agogo, you can go next. Your final thoughts, 1 minute.
Okay. Hi, I think, thanks for the opportunity. opportunity to have this conversation with my good friend Aban and Suleiman. You know, this is a complete area that we need to like work on collectively. I think, you know, a lot of hands need to be on deck, and as we do this work, we need to like collaborate a lot more. And I think we need to support and build our systems, because at the end of the day, our government systems are still integral. The state epidemiologists, the local government DSNO, the data entry clerk at the health facility, these are the real heroes of the work that we do. So we need to like support them and make sure that they are adequately resourced to keep doing this work. Thank you.
Dr. Aban?
Okay, thank you. More than ever, I appreciate the local context even more. Quite some interesting perspective coming from the other panelists. It's obvious that technologies seem to have been settled. Interoperability is also settled. There are issues that we are navigating around, and we seem to have found solutions. However, I do see that the local context, it's a little bit more complicated, and that's probably where we have to start looking at emphasizing. And I'll probably be reaching out to colleagues, even eHealth, to see how we can talk a bit more, how we can improve this IDSR context and also improve One Health surveillance. So I'd like to leave with the fact that I think the game changers could be that if we added One Health surveillance properly, recruit vets, recruit partners around that, and that would mean we would catch the next zoonotic disease faster. And then we keep improving capacity, training at that lowest level. And then one thing that I think our continent could possibly do, I keep thinking about it over and over again, it's have data or toll-free lines that can just pass data that has to do with health, pass surveillance data, pass vaccination data, totally free, so that we don't worry about things. Do we have data? We just know that once we have a mobile phone at the lowest reporting level, we do have our data. And that is something that the International Telecommunications Union, alongside with governments of countries, I know a strong country like Nigeria could possibly advocate for that. And if we get that right, I do think that that would be a strong game changer in improving disease surveillance across the African region. Thank you.
Awesome. Thank you so much. And it was easy to actually see exactly what the power of mobile technology, especially in the hands of, you know, community informants at the local level. I like to reference back again to Harvard, because it was a lot of lesson with regards to the power of technology in disease surveillance. That said, I want to extend warm thanks and a specific appreciation to our panelists, Suleiman, Dr. Agogo, Dr. Aban. You guys basically came through at very short notices, and the presentation here basically belies the shortness of time it took, you know, to get to put this webinar together. Let me ask David Aban, our Deputy Director for Programs and Impact, to provide his closing remarks so that we can then adjourn the section.
Yeah, thank you, Chinedu. I think super excited about the conversations that we've had so far, just to further buttress how much data can help us in terms of improving our public health response in Africa, and I mean, even also considering Nigeria. And thanks to our very distinguished guest panelists, you've done so well in terms of highlighting all the issues that needs to be taken forward. And we appreciate that. So for our attendees, so thanks for staying all through. You are actually a superhero, and it means that this had been of great interest to you, and we appreciate that. So questions we had not been able to attend, respond to at the moment, we will definitely get back to you with those responses. I'm sure our panelists will provide some clarity to those responses. We're happy to let you know that we will also communicate to you the video recording of this particular webinar. We'll send them to the email you provided us during the registration. So thank you, and we appreciate you. So look out for another insight coming to you next month. And we will be glad to bring to you another interesting topic for discussion. Thank you.
Excellent. Thank you, Dr. David Aban. I will, on this occasion, basically thank everyone who made this possible. EHA Help Desk, led by Solomon Emmanuel, our communications team, Uche Munachi, Sunday James, Favor Oriako, Juliana Jacob, and Juliana Okora, and everybody from eHealth Africa, who basically had a hand in ensuring that this took place. You guys are actually the hands behind the scene, working to ensure everything went smoothly. Totally appreciate your professionalism and approach in terms of making this first edition of EHA Insights to have taken place. And we recorded about over 103 attendees participating. Please keep an eye on your emails. The notification for the next cycle that will happen about this time next month is going to come in soon. And we will be featuring a very interesting panelist and information exactly with regards to the work we do in the field. On that note, warm thanks and appreciation to you all. And we would now adjourn the setting to next month. See you once more. And have a wonderful week and a wonderful time out for the rest days of the week. Over and out. Goodbye, everyone. Bye.
Thank you. Bye-bye.